Before our final event of the day, we're going to have a clinical case presentation highlighting a mental health case in the African context. And I hope that there's a lot of group participation for this part too. So Dr. Saeeda Paruk from UKZN will be leading this.
Good afternoon, everyone. You've been very privileged to have had lots of giants in our global mental health field speak to you over the past day and a half. And we are hoping to have the emerging giants in mental health speak in the afternoon. So I'm kind of sandwiched between the two. So a little bit of very huge footsteps to try and fill in. But generally in the previous AGMHI meetings, we've had traditionally a breakaway session in the afternoon of day one or day two, where each working group spent some time reflecting on how they could plan the year ahead. So this year we thought we would change. Well, initially we were going to still do break groups, but then we decided to change, and we're just having one case discussion, which reflects the critical need for the 4 working groups, and will hopefully help you reflect and inspire you for the next year ahead. So without further ado, let's begin. You're welcome to interject, discuss as we go along, etc. So we're going to talk a little bit about mental health, and specifically child and adolescent mental health services in Africa, a short case discussion, and then possibly how can we change our current reality in mental health. So we always talk about the definition of mental health. I tried to look for a definition for child mental health. There isn't a really nice definition, but essentially it's defined as being mentally healthy, reaching developmental and emotional milestones, and learning healthy social skills and how to cope with our problems. Mentally healthy children have a positive quality of life and function well at home and in school and in their communities. So obviously having mentally healthy children would hopefully result in mentally healthy adults, because we know the life trajectory is that if you have adverse life events, negative mental health experiences, and events in your childhood, the likelihood of adult psychopathology is much higher. So it should hold interest for the adult psychiatrists and mental health care workers in the room as well. In 2023, the theme for Mental Health Day was Mental Health is a Universal Human Right. And I would just like us to remember that as we go along, because I think often we forget that children have an equal human right to mental health. A lot of the focus is on adult mental health, if any, and mental health firstly is just neglected, but child mental health is sometimes not even acknowledged in some settings. So the WHO report on caring for children and adolescents with mental disorder highlights that 20% of children and adolescents suffer from a disabling mental illness. Suicide remains the 3rd leading cause of death amongst adolescents. And major depressive disorder, which often has an onset in adolescence, across diverse countries, and is associated with psychosocial impairment and higher risk of suicide. We also often have conduct disorder or behavioral problems in children, and these often tend to persist into adolescence and adult life, and frequently associated with complications such as delinquency, adult crime, dissocial behavior, interpersonal relationship issues, unemployment, and poor physical and mental health later. So there's an urgent need for us to address child and adolescent mental health, not only because of the issues it has in the childhood, but also of the implications it will have later. Unfortunately, also half of all mental disorders and substance-related disorders begin by age 14, and 60% are already prevalent at age 24. So bearing this in mind, there's obviously an urgent need for us to address child and adolescent mental health services. access to mental health care obviously would be critical, firstly. And ideally, we should have this beautiful pyramid with self-care at the bottom. And as we go through the different levels of care, from informal community care to mental health services to community mental health services, and then obviously the specialist at the top. Unfortunately, many levels of this pyramid don't exist in our society, and we probably have a little bit of community and psychiatric care, and we probably have a little bit of specialist care. And unfortunately, in Africa, even psychiatric specialist care in good settings is about 1.5 to 2 psychiatrists per 100,000, to some like 0.01. Actually wrote it down because I didn't want to misquote this. Chad, Burundi, and Niger have 0.01 psychiatrists per 100,000 people. If you had to look at the bed numbers per 10,000 population, again, a very sad picture with many countries still having less than 10 beds for 100,000 people in psychiatry. So obviously our ability to provide care comprehensively for these individuals is very limited. In Europe, there is currently 20 psychiatrists per 100,000, and they still have gaps in their care system. So, what is the state of child mental illness in Africa? This was a paper written by Philip Owen et al., and in this paper they highlight that obviously the ability for us to really provide good statistics on child and adolescent mental health services in Africa is limited because we don't have good data and we have very limited research on the subject. Screening and diagnostic tools are also not adequately validated for the different cultural populations that we have, and therefore may not always be accurate in what we're trying to test or assess. And we still have to consider that these children may have different socioeconomic and cultural context, and therefore our tools would need to be adapted accordingly. They also noted that 27% of the countries that are designated with child and adolescent beds, other countries don't have a child and adolescent in hospital service. So in most countries in Africa, there's approximately 1 child psychiatrist to 4 million people, which is really a shocking figure and no way going to address the need that we have. Children still often begin with a traditional healer or a faith healer, and then they may try other routes, often pediatricians, if that's available, or a general practitioner. And the ability to actually access good child and adolescent mental health care is limited. There's also the role of stigma. Many families, many parents don't want to acknowledge mental illness in children. So that in itself is the first barrier that we have to still overcome. How big is the treatment gap? So in the US, they're worried about the treatment gap because they're saying that they're still not seeing everyone with the disorder. In anxiety disorders, they're seeing about 30% of the children they should be seeing. Conduct 40, I think where the child gets more disruptive, you see more of them, right? So obviously the ADHD and conduct, you're seeing more of the kids that need to come through, but obviously the depressed and anxious child, a lot of them are still missed, right? And that's the US data. In the African setting, we think less than 10% of children who need to access care are actually getting care. And it's not that the children don't have a mental illness. It's just that we don't recognize it, we're not screening for it, and only that child who's really disruptive is the one that's being brought in. I had to take a call just now because a child tried to set a car light. So that's when you get called. And this child sounds like he's had behavioral problems from early childhood. So I'm not going to spend a lot of time on these slides because I would like to allow for some time for discussion, but obviously risk factors for mental illness in children is multifactorial. We've spoken extensively in the past day and a half about the role of environmental factors, things like COVID, climate change, negative life experiences, adverse childhood experiences. So I'm not going to go through all of that. And together with biological vulnerability, these children are very vulnerable, bearing in mind that Africa also has high rates of HIV. We still have lots of infectious diseases. Our ability to have families that have employed parents and good homes, etc., is still challenging. So as family factors increase, the risk of mental illness also increase. So coming to our case. So this is an 8-year-old boy. He was accompanied by his granny, and his dad is not known. This was the maternal grandparents who have raised the child. Mom has passed away about 3 years ago. Grandparents seem to deny that there was any other acute stressor. So he was in a mainstream school, doing okay, passing each year. And he presented to a remote hospital in KwaZulu-Natal with a 1-week history of respiratory symptoms. They initially thought it was an asthmatic attack. They treated it accordingly. He failed to respond, and if anything, he progressively got worse. He developed pain. Initially, it was back pain, then became more generalized. He developed paresthesias and became progressively weak and felt he could not walk, so he was eventually even in a wheelchair at one point. Because of the poor progress and the lack of clinical response to the treatment they were providing, he was then referred on to the regional level hospital. And from the regional level hospital, he was eventually transferred to a tertiary level of care, where he developed mutism and had stopped walking altogether. Extensively investigated. They did all kinds of hematological tests under the sun, autoimmune screens, infectious screens, neurological workup. They included autoimmune investigations, and he had neuroimaging of the CT brain and MRI of the brain and spine. Because when he stopped walking, they were worried about a spinal pathology. He was seen by the pediatricians, the pediatric neurologists, the orthopedic people, social services, OT, physiology, etc. at this hospital. This hospital is actually about 5 hours away from his home. And this whole process took about 3 months. At the end of the 3 months, when they were ready to send him home, they phoned me to say, "Can I come in and just see what I think it is?" So they don't have this tertiary level hospital does not have a psychiatrist or a psychologist. So he was discharged back home, but he had to be readmitted because he became sick as soon as he got home, and he was then had to be managed at his local hospital. So we'll discuss that just now. At that stage, the differential diagnosis they entertained, Lishle, this is not my differential diagnosis. This was the differential of the pediatric neurologist who was seeing him at the time. But they were entertaining Guillain-Barré syndrome, and they even gave him the benefit of treatment, although he was negative on investigation. I'm not sure why a complex regional pain syndrome, because it wasn't regional at all. It was more, he complained of pain everywhere. They considered an occult neural tube defect because the MRI found an occult spina bifida. But it wasn't in keeping with the neurological signs he had. It wouldn't explain everything. It was more coincidental finding, I think. And they also obviously considered an acute demyelinating encephalomyelitis. So these were some of the things they considered, but his symptoms were not physiologically in keeping with his physical examination or any of the investigations. And despite even giving him the benefit of course of antibiotics, treating GBS with immunoglobulins even, they tried. And then they eventually said, well, I think it's time for the mental health care people to come in. So from our side, some of the differentials they had was, is this a factitious disorder? Was there a reason for the sick role in this patient? But he obviously wasn't, we didn't think this was malingering. There was no secondary gain. Was this a functional neurological symptom disorder? Was there an underlying associated anxiety or depression, which may have been long-standing? He's had adverse childhood experiences. He's had a loss of a parent, absent father, being raised by grandparents. So there are multiple challenges. So we eventually settled on functional neurological symptom disorder, and we treated him for an underlying depression, because he was mute at the time. So it was very hard to make out how depressed or anxious he really was. So traditionally, when we do a case discussion, we discuss the diagnosis, we're going to discuss the clinical features, we're going to discuss the differential and management. But I'm going to suggest we change a little bit and not talk too much about functional neurological symptom disorder, because you're all psychiatrists, psychologists, I don't need to teach you that. And rather, we look at the bigger picture. So functional neurological disorder is something that has complex psychopathology behind it. It is fairly common in pediatric practice, with up to 20% of children in specialist epileptic clinics presenting with functional neurological disorder. And often children with epilepsy may have pseudo-seizures. That's a common type of presentation. It does place substantial psychosocial, educational, and financial strain on children and families, and often inconsistent examination with no physiological cause to be found. But what's important is this is telling us that this child is not coping. There's something going on that's making this child present the way they are, and they're just not able to express it. So in terms of the diagnosis, we can look at DSM-5 criteria. I'm not going to go through them, but essentially it would be important to exclude a medical condition, because that's the last thing we want to do, is miss out on something that is quite important. But I think the important thing to realize is that this child is also not purposely doing this. They don't realize that these symptoms are not related to a physiological basis. This is just their way of expressing the underlying conflict. Treatment obviously requires a comprehensive assessment. It requires a multidisciplinary team and the development of a treatment plan. And generally one would require, depending on the presentation, even involvement of psychology, OT, physiology, looking at the child's school needs, treating any comorbid anxiety or depression, and then a discharge plan with ongoing support in the community. So this is all really nice. But you need to have these things in place to do it. Okay, so what was the context of the child that we saw? So my reflections are that firstly, it took 3 months for this child to even access mental health care, even in the health system. There was no child psych unit in the province, so at age 8, he cannot be admitted to a psychiatric facility. We would have to admit him to a pediatric facility. The pediatrician's response in Durban was, the child is going to be disruptive, psych patients are disruptive, and he does not want to admit the child to this Durban unit so that we can at least co-manage the patient. But that was the kind of reality and stigma we face. It was, I think, only because the child had this dramatic presentation and was not walking and not talking that he didn't get just passed off and sent back home. They had to kind of do something for them. So this is our reality. KwaZulu-Natal has 20% of the child population of South Africa. And we do have, I think, 40% of our population is under 18. So you can imagine what a number that is. Okay, in a population of 51 million people. So a large child and adolescent population with very, very limited access to care. Unfortunately, many children are still orphaned in our setting. And as you can see here, that at least 15% of children have only one or no parent, like this child had. Access to healthcare. So this study looked at access to healthcare in I think it's 2002 and 2019 to see whether we've improved or not. We have improved. Our ability to access care within 30 minutes of leaving your home was looked at in this study, and it did improve. So I think now majority can in 2019 in KZN, 20% can't access, but at least 80% can access some kind of healthcare facility within 30 minutes of their home. So what was this child's reality? This child came from Paul Petersburg. We won't discuss the name of the town, but it's on the northern part of KwaZulu-Natal. It's a little town which is quite touristy, but unfortunately doesn't have its own hospital. It has a community health care clinic. Okay, so the community health care clinic has a registered counselor and it has a mental health care nurse. Then the child had to be moved to the next level of care, which was Vryheid Hospital. This hospital has a psych doctor, not a psych doctor, but yes, a medical doctor who has some interest in psychiatry, so works in the community service. And there is an outreach psychiatrist coming once a month. And then the next level of care is a regional level hospital, which has pediatricians, but it does not have a psychiatrist. The two psychiatrists in that region are based at another hospital, and they provide an outreach service and telephonic consultation. Okay, this hospital, Queen Nandi Hospital, was at least an hour away from his home, if not a little bit more. If he had to come to Durban, it was a 4-hour drive to come from where he lives to Durban. That's if he had private transport. Okay. So that's the kind of context. There are 2 child psychiatrists for the province of KwaZulu-Natal currently in state sector. And in case you're wondering if I'm just trying to make this picture look worse than it is, the research kind of bears me out that the services in KZN are very limited. So, what is it like in the rest of Africa? Unfortunately, the picture is fairly similar. And in this survey where they looked at the perspectives of mental health care clinicians in terms of the child and adolescent services, everyone recognized that there's an increased need for commitment from the governments, particularly in relation to both policy and funding. There's a need for us to have more specialized child and adolescent mental health care facilities, and the need for multi-sectoral and multidisciplinary partnerships for advocacy, service delivery, and continuity of care were also identified. Similarly, surveys in Ghana, Uganda, South Africa, and Zambia have shown the same picture. And Africa is not alone. Many low and middle income countries face a similar picture. In Brazil, they have exactly the same type of challenges. There have been, on the good news part of things, there are attempts to cut down the treatment gap, and people have looked at new types of programs, including the firm policy. In terms of the WHO Atlas, which reports on mental health care from each country, we have again noticed that more countries are reporting on mental health services, more countries are now having policies, mental health care acts over time. Of note in that report is that the 2019 report showed that 39 countries in Africa responded to the Mental Health Atlas survey. 11 countries had standalone child and adolescent mental health care policies or strategies. 9 had inpatient services for child and adolescent. Okay, this is 9 out of 39 that reported their data. And 12 had outpatient services, and 5 countries had good community-based child and adolescent mental health. So in South Africa, we do have this document. I'm not sure how many people have read it. It's quite an old document. It was written in some time ago, and unfortunately, implementation has never really occurred. So, what about funding for child and adolescent mental health services? The WHO reports that on average, African ministries of health allocate about 90 US cents per capita to mental health. And this is obviously totally inadequate for our needs. Often these are also allocated to large psychiatric institutions in the cities, and people out there in the community still see no difference in their mental health care services. What is quite important is that they suggest that if we had to spend a little bit more money on mental health care services, we would actually save in the long term. So if we had to spend $1 US for every $1 US we spent now, we could save $21 US in the long term, because we would then cut down pathology, improve healthcare, and have a lot less consequences, both mentally, physically, socially. But obviously people need to understand that bigger picture in terms of why you should spend money on this now. So what are our strengths and challenges? And I'd like people to start interrupting. I think the reason I've outlined it in this way is because it matches our AGMHI working groups as well. We need advocacy and policy. Okay, so we need to now start pushing more. Why are children not receiving? Why is there no child unit? Why is there no adolescent unit? We need to advocate with our patients to maybe take this up legally, to maybe take this up in terms of having their own groups that lobbies the governments. We need to look at policy and the implementation of policy and hold people responsible who don't implement. There's a large aspect of clinical care that we can assist with in terms of in training people to do screening, to provide better access to healthcare, resources that we could look at. Because we do have some resources. We do have general practitioners. We do have pediatricians who are larger in number than mental health care workers, psychologists, social workers. There's like an 80% vacancy in psychology posts in South Africa. So, there's a space for us to do more. Medications, what do we have access to? Which areas have access to what? How can we maybe look at making sure everyone has access to a basic antidepressant, methylphenidate, some antipsychotics? And then what health facilities do we have, and how can we maybe incorporate child and adolescent mental health services into the existing structures, so that at least they have some opportunity for treatment when required. We also obviously require a lot more research in this area, and then obviously training and education around these aspects. So, in each of our working groups, if we could reflect on how we could better assist the patient out there, because at the end of the day, that's what it's all about. We have AGMHI to actually not change the trajectory of the life of many children out there. There's very nice models, so we don't even have to go and figure out the wheel again. But it's a matter of where do we interject in this model? Where do we start? How can we each help strengthen the system from individual and community level of care to the tertiary level of care? And then in terms of strategies to build child and adolescent mental health services, I think we need to look at whether we can advocate more, which I think we can, how do we involve every healthcare worker out there, from our community mental health care workers through to our specialists and subspecialists. How do we include mental health care in the undergraduate program of all different types of mental health care workers? It shouldn't be just the privilege of a doctor or a psychiatrist. I think, if we have, even a dentist should have some ability to screen and see whether a child is having a mental health issue. A social worker should have mental health care as an important part of their curriculum, so that we at least improve our manpower and our human resource. the ability to task share would make a big difference. I know there's a lot of debate about task sharing, but I think at the end of the day, we also have to do the most we can with what we have. And then obviously continued professional development and support for those who are working in mental health care. So my presentation is quite short. I just wanted to also acknowledge that I think AGMHI is doing a lot of work, and I think we're in the right place, and we really have the 4 working groups which really try and meet those needs. But I think there's also a lot of place for us to still improve. There have been lots of initiatives, Anusha's initiative in terms of infant mental health training, and all the presentations we've heard over the past 2 days all reflect what is being done, and I think we need to now start sharing that knowledge, learning from one another, so that we build on it. So I'd like to now open the floor to discussion. The point was to have some discussion around this rather than just it being a monologue. So we'll take some comments, questions, thoughts.
Thanks very much. My name is Michelle. I'm a clinical psychologist, and one of my most enjoyable years was in my internship at Town Hill Hospital. And they developed an adolescent unit. As part of the outpatients department, I think it was. They built a whole new section there. But there were so few admissions, because obviously there was a long waiting list. But they had quite a lot of success with the model that they used, but they would admit them for quite a few, I think it was at least a month or so, and they would have to be involved in chores. They ran it like a unit, where they were almost sort of being fostered while they were actually being healed, and then to my knowledge, I'm not sure if it's still going, but it sort of launched as this, public health adolescent unit. And then everybody was trying to get, children in. And I had 2 admissions that went in that really did very well. But I'm not even sure if it's still going. But that's the only one I know of in KwaZulu-Natal.
So there is a 6-bedded adolescent unit in Pietermaritzburg. It currently does not have a child psychiatrist. But it does have a bit of an MDT and a psychiatrist running it at the moment. Yeah.
Thanks, Prof. Litlem Gweba. So, Prof, I wanted to ask, how's the child doing now?
So what actually happened was we eventually had to work with the hospital that was near home for him. Because obviously, his family needs to visit, etc. as well. And also the Durban hospital was not going to keep him for the psychotherapy and psychological support. So the psychologist there, with the support of this psychiatrist and psychologist at the regional hospital, looked after him. We had telephonic and Zoom meetings to case discuss him and look at his progress. And he is now home, so that's good. But he also still needs ongoing support and community care. So I'm not sure how that's going to work, and I hope he doesn't fall through there's lots of gaps in the system. And sometimes these kids fall through until they have another problem, and then they get brought in again. So for now, he is back home. And it was also interesting to see how the pediatrician and the psychologist, they work together to help this child. So that was quite good. Yeah.
Good afternoon. Good afternoon. Yeah, I'm Jane Kara from Kenya, the only nurse in the house. Okay, she has reminded me over 10 years ago, when I was just employed, we had such a case. And then I had no okay, I had basic psychiatric information. So I never knew what was happening to the child. Somehow I realized that the child was missing the dad. That's all what came in my mind. Because the dad went into politics, he became an MP, and immediately the child became what she has described. And when the MP called the ward where I was working, in Kenya we call them muheshimiwa, and like Your Honor. And I told the man that, Your Honor, I think your daughter is missing you. Your daughter is not sick. And then I told the girl, Daddy is calling you. And immediately the girl started talking and started walking. And I was relating with what she was saying, and I'm realizing the death of the parent brought this. And my question was, how is the child?
Listen,
But you have already
yeah,
answered. You have
yeah,
already answered
yeah.
that.
He has improved, but obviously I think it's a very vulnerable child. So he would require ongoing support. The problem is if he misses the appointment, no one's going to phone and say, where are you, what happened? You know, you need that kind of interest. You need a social worker to go and visit at home, see what's going on, check in with the teacher at school. You know, there's no case management, unfortunately, in a lot of these cases, especially out there in the rural areas. Yeah.
Thank you, Dr. Paruk. My name is Annie. I'm from the team with Boston University. I've had the distinct pleasure of learning under Dr. Lunga Shabalala. She's been staying with us these last few months, and she was letting me know that there are 11 official languages in South Africa. And I was talking with her about how that may or may not affect care, and I'm wondering if that's something that you've experienced with the child and adolescent group, how often language may be a barrier for some of the patients that come through, and those that might have to cross multiple boundaries just to get to a point where they can receive care. So how does that affect the children that come through? Thank you.
Definitely, I mean, language is a major barrier. Sometimes with the younger children it's easier because they speak English now. But at the same time, the way they're going to express something is not necessarily the way someone in the US would express something. So you have to appreciate that. There has been a lot of literature around the challenges of the language in not only in healthcare, but in mental health care. I think Prof. Kalisa has even written something. So it's definitely a challenge, and sometimes may miss the finer subtleties of what they are trying to say if you don't understand the language and you're using a translator, because they may say a whole lot, and then the translator gives you like 2 lines. And I'm like, really? And because they just think they're going to summarize what happened, but you miss that whole story of what exactly happened, and you have to say, no, like, tell me again. So definitely, having someone who speaks the language makes a huge difference. And that's why we need to have people from the community so that they can then go back to their communities and be able to practice better.
So, and I think that it's really interesting because obviously in our unit, we always think the Western Province, Western Cape is a different country to South Africa, in the rest of South Africa. But I think there's some value in it because the translator doesn't always help because there's also a power dynamic there in terms of if they're older, whether it's an older male or female, whether they look at them as a peer versus a parent figure. And so what's really been helpful in our unit, in our sister unit at Lenta here, the child psychiatry unit, is the opportunity to partner up with other creative ways of doing it. So there are drama therapists, there's drumming groups. We've had an NPO do hip hop dancing as a way of communicating. We do a lot of therapeutics that are nonverbal, which kind of try to remove the need for you to be particularly eloquent in communicating it. And also contextually, children don't routinely, so when I teach the registrars, the children don't routinely come to you and say, I'm depressed or I'm sad, but they can be really angry or really mad. And so the question to always ask is what's underlying that? And often it is a mood disorder or something else that's happening like that. So we try and teach in a, or sort of explore in a non-threatening way by default, because we don't have the luxury of language and somebody delivering that kind of engagement and intervention in that way. And then I wanted to also just then pick on what Saeeda's, the case you have is not unusual to what we see, especially in adolescents. I run an adolescent unit here. And we often, or not often, but it's not unusual. And we've recently had one with a child who was raped on her way home, but by the neighbor. And so she had to see this person all the time. And even when he was out on bail, and her only way around communicating distress was to stop walking and stop talking. Because if you have a physical expression of the distress, you are taken more seriously than if you're sad and you don't want to function in other ways. And so she was actually in the community because unfortunately we normalize the rates of violence and abuse against women and sexual trauma particularly. People couldn't understand what the big deal was because she had access to a clinic where she could see a psychologist, and she was taken to the Zela kind of sexual trauma support. So what was the big deal? You know, and the big deal was, it's always a big deal, but we kind of minimize it because of it, especially with children. So I think that it's not an uncommon scenario where we are faced with children present with somatic symptoms very commonly. And the other reason we also have an 11-year-old who's in a wheelchair waiting for an admission, and he has a father who's psychotic and stays at home in Paarl, which is like a district area, a little bit of a rural area. And the difficulty there is we've sent out the outreach team, we've asked adult psychiatry to go, and they've said they can't bring an adult person into hospital unless the family, kind of asks for the certification. But this family is a very traditional, very church-based kind of, and the pastor feels that the family must be more together and pray and be at home. And so this man has been at home for a year, where he's quietly psychotic. The wife refuses to take him to hospital. The only way for this child to get some of the distress communicated is the child has stopped walking. And now suddenly the child is a function of, a symptom of what's really underlying. And what we've been trying to say is that there's very little we can do to intervene here for the child. Of course, we'll take him to our ward. But until somebody addresses the bigger systemic issue, and that there's no such thing as just a child or a baby, the baby exists in the context of a family, there's very little that can happen. So I think that it's always important to keep that in mind. It's not so much that we don't have the resources to do it, it's the thinking that has to be more family and context directed rather than child and patient directed. And I often think about that. I spent some time in Finland, which has beautiful mother-baby units, and they admit the mother and the baby for months, and they do these wonderful things, but that would never work here. People would say, but isn't that an ideal? It's not an ideal, because our babies don't live alone with their mothers. You'd have to admit the whole family, and the extended family that lives in the yard for you to do something like that. So it really, these clinical cases are about us thinking in context. And what is useful in this environment. So I think we have to be thinking about what are the kind of interventions that would be more appropriate but also Afrocentric. And I'm hoping this is what the clinical work group kind of looks at in terms of focusing. So far we've been doing a lot of education and a lot of those kind of information related, but we really need to grapple with the core clinical questions that we have. And what are the answers to that? And how does it look in a different setting? And again, just to remind you that it's not the resource that's always the problem. It's the idea. And sometimes ideas don't currently exist. All we're trying to do, we were talking earlier, is all we're trying to do is validate tools. But really, are those tools appropriate? Is that how we should be screening? Is that how we should be intervening? That's the kind of conversations that we really want to be having in this clinical work group so that we can address that better.
Okay,
Thanks, Anusha. There's a hand here that's been up for a while.
Okay.
Okay.
Should I go ahead? Okay, thank you. Thank you. I think this is such a rich discussion and it's very stimulating, a rich learning experience. My question or contribution is around the application of a healthcare delivery model to different contexts. And so I come from the Eastern Cape. I'm Siki. I'm a new psychiatrist, work in the Eastern Cape in Grahamstown. And similarly, similar to KZN, it's a vast province. We actually only have one child psychiatrist, and that's a new development. Previously didn't have a child psychiatrist. And we have one child psychiatry unit in the province, which is housed in Grahamstown, where I work. And, you know, it's serving the whole province of the Eastern Cape, which, I mean, you can literally travel 6 hours being just in the Eastern Cape. It's a vast province. And as you spoke, Prof. Paruk, I was thinking around the application of the tiered model of healthcare delivery and whether or not it's working in regard to delivery of child psychiatry services. So the whole notion that, you know, subspecialists belong in a tertiary level facility or hospital. And I'm sort of grappling with whether that works in our kind of context. And the fact that, you know, this child that you presented had to drive 3 hours to access services which actually were not completely, which did not completely address their needs. And I guess I'm kind of saying perhaps that's one aspect that we might need to grapple with. Do we fit ourselves into the model of primary, secondary, and tertiary level hospitals in delivering child psychiatry services? Or do we need to rethink that? Do we need to adapt that to what we have available? And even just bearing in mind the contribution Anusha just made, that perhaps with the resources we have, not necessarily saying we need additional resources, but with the resources we have, you know, how can we, how can the services with the resources we have become available to the communities we serve most appropriately? Is the tiered model working for delivery of the services without necessarily compromising the patients we serve and their access to the services?
That's a very complex question. But it's open for discussion. So, you know, I think the issue is, obviously we need to look at how can our 1 or 2 child psychiatrists per province, I think Western Cape, okay, you're a separate country. But how do we better address the needs of the children in that province? I also think we should, you know, Anusha and I were talking, we need to share within South Africa, firstly. So we should be making sure that a lot of people go and visit Anusha's unit, spend a month with her, so that we build capacity within our system, firstly. And I don't think we can wait to create enough child specialists. So that's not an answer either. Because, I mean, to become a child specialist, you need 6 years medical school, 2 years internship, comm service, medical officer time, psychiatrist time, subspecialist time. So that's like a decade in itself. So I think the solution obviously lies in how can child psychiatrists better support the service, make themselves maybe more accessible. I mean, here we use telephonic support. We had joint meetings. I actually had to drive out to that hospital and see the child because there was no one else to go there. So you kind of have to adapt the system so that it works. But it's not always possible. It depends where the hospital is and who is available. But I think definitely we need to relook at our model. But also that's why I think it's important that there be mental health awareness amongst the community. There needs to be our healthcare practitioner, no matter who you are, should have some basic understanding of mental health issues. We need to recognize that mental health is just as important as them screening for blood pressure and sugar. Our community health workers that we had in South Africa were really targeting, firstly it was HIV and TB, and then more recently it became the non-communicable diseases like hypertension and diabetes, etc. So there should be advocacy that they should now start looking at mental health. If a child hasn't been to school or suspended from school or drops out for whatever reason, they should be saying, why is the child not at school? Let's send this child to the nearest hospital for an assessment. It's not, child psych assessments are not always easy, they're complex, but at least if we could do something like that. We often see children who are like 10 years old and can't read. Because each year we have a system where if you fail the first time, then the second time, no matter what, you get promoted. And if you haven't had access to an educational psychologist, etc., you're just staying in the system, but you haven't actually learned to read. So there's, multiple systematic issues.
Very interesting. So, of course, my mind is wandering all over the place. What were the life issues that finally brought this young boy down? So that's one question. And the other is a comment on, do we have tools that we can grapple with and use in situations like the psychotic family or the father of that child? Could that man be declared incompetent and therefore services proffered because he was a danger to his son? In the sense that, I know it's really far out, but in the sense that his not accessing care had a direct impact on the life of his son. And who next would be impacted by that refusal of care? Yeah.
Laws that govern how we treat children. And one is the Children's Act, which supersedes all other acts, which is protection of children's rights and access to care. And the second is the Mental Health Care Act. So unfortunately, in cases like this, where the Mental Health Care Act is what we're trying to utilize to get this father admitted, and they're saying only the applicant can be a family member or a relative that wants to get him treatment. But if we look at the angle from the best interest of the child, I guess is what you're asking, absolutely, 100% that's what should happen. That the mental illness in the parent is denying the child access to care and is resulting in a psychiatric condition. The challenge is that social services are wholly inept in South Africa, almost non-existent, very poor training in terms of mental health care. They don't understand the complexity of that and the influence of the parent and the child. And there are no facilities. Oh, sorry. There are no facilities, unfortunately, and it is a critique on the Department of Health and the Department of Social Development, where we're needing to collaborate in a way that can get people to understand that it is actually a best interest in the child issue rather than anything else. Also, it's really hard to remove a child from any care. And especially to remove them from family setups where you can't directly prove that there is an impact, if not physical, on the child.
But can you test this through, we have what we call the SHRAJ, it's like an ombudsman,
Right.
Not for mental health,
But for
But
children.
in the legal system,
Yeah.
where we've sometimes applied for the right to treat a child from SDA, what's SDA?
It would be the equivalent. So it's the High Court that is the upper guardian of all children in the country, and they answer to the Constitution.
Right.
The Children's Act is the highest level of the
Yes.
Act.
So
So
could that be tested?
it could,
And maybe that's where we have to go.
with an NPO maybe.
But I think firstly we need to get social service, DSD, Department of Social Department Services, to investigate the home circumstances, because it would not be fair to supersede the rights of the family and the individual and go to High Court without having adequately investigated. We don't know this man, we haven't seen him, we haven't assessed him. So, I think first we would need to do our homework properly before we go any further. We're actually out of time, unfortunately. I'm doing Michelle's job.